My first question is how might it be so that this HIFU treatment will be more wanted by more patients, and that it will be harder and harder to kind of stop people asking for it? Did you understand my question?
Yeah, of course.
I don't know. I'm not sure that we do want to stop people asking for it. I think it's just about selecting the right patients. You have to say no to some patients there. And I mean, the last patient is not a good candidate for HIFU. He had a Gleason 8 cancer, so you should be operated.
But I thought that it is kind of convenient for a person to choose the treatment that is the less harmful.
Well,
yes. In first case.
Yes, but still, I mean, some patients have serious prostate cancers and they need aggressive treatment. And like some of these examples showed, or the Hafner study that we discussed in the break, show that even despite this aggressive treatment, the outcome is not good. I mean, this is another thing. We kind of always give the impression that, okay, if you operate it or get radiotherapy, then you're cured. You're not. There are some really tough cases that no matter what treatment you give them, they will fail the treatments you give them. And I mean, the patient you showed was actually quite interesting because there was nothing in the prostate. So no matter what kind of local treatment you would have given this patient, he would have ended up with lymph node metastases. So,
So if I see a patient, I always ask them if they're more the adventurous type or they just want to get rid of the problem. If a patient clearly says, I want one shot therapy and then only PSA testing for the rest of their life, he probably is better off getting surgery or radiotherapy. But sometimes patients accept that it's a little adventure that we both are going on, and then we can offer a HIFU. A HIFU therapy often has less impact on quality of life, or almost every case. But then later on, you need biopsies, you might need rebiopsies, and you might actually need a surgery later on. So the patient clearly has to have the mindset that he needs checks, and the surgery might only be delayed. That's the only safe path I see at the moment.
We have one in the audience, Sophia again, but you need a microphone, so let's get the microphone for her. No, I remind you that we are taping things, so everybody should listen to you, not only the people in this audience.
One thing is, if you want to...
I close the microphone.
If you want to know the place of this therapy, in comparison to the accepted curative treatments, which is active surveillance alone with actually local treatment later on, or prostatectomy or radiotherapy. What about the health economics? Because I think health economics are today very important. Here the patient has to come back and to travel. Norway is a large country. And who should pay this in comparison to do a prostatectomy and have it done? I just ask. I don't know, because I think we have not looked to health economic problems in prostate cancer, in radical prostate cancer treatment. We will do it very soon because I have become interested in it. Thank you.
Thank you. Yeah, the economy.
So we looked at that, but it really depends on the healthcare system. But keep in mind that we're talking about a man that is front of you. If you do surgery and you're a very skilled surgeon, he has about 60% of erectile function, if he's good. And if I do HIFU, he's probably about 85 to 90% has an erectile function. So that's a big difference. So even if that would cost a little bit, I would probably understand that the patient would like to have it. Right now, we did the math in Switzerland, and HIFU is about half the price in the long run if you connect with all the biopsies and a radical prostatectomy. So even it is the better choice.
So it is also in the long term cheaper than the alternatives?
So looking at the data, that only maybe 18% might require surgery within 3 years. We don't know now 5 to 10 years, but usually it flattens on. I believe yes. So for the health carriers, it would be very interesting to endorse HIFU, I believe, but we'll have to see in the long run. We don't have the data set complete yet. Yes, so we have 7 years data out of London, which are mimicking the results I showed you. There's only a very few percentage with later on that would need radical prostatectomy. Just keep in mind that the patient group gets older as well, and then they come back with 80, and they might have some, they will not get surgery anyway.
Okay, Carl?
Yeah, Daniel, thank you very much for coming here.
Sure, it's a pleasure. Thank you.
Great honor for us. You are on the EAU guideline committee, and you're developing guidelines for HIFU treatment as well?
That is correct.
Yeah. Could you tell us a bit more about that, please?
So, yeah, I mean, again, the European Union really tries to make a fundamental good guideline for prostate cancer. And you know, it's a very thick bundle of paper if you really read it. And we are trying to really understand where we are. But it's very crucial that you also understand that the guideline can only work on very good data. Now, the question that I always ask, why is there no randomized controlled trial? Some people get a radical prostatectomy and the other ones would get HIFU, and then you compare them. There is actually 3 trials that are ongoing, but they all will not give good data because the dilution is wrong. People who are randomized to surgery, 28% said, I'm not going to show up. They wanted HIFU. So even if you randomize them correctly, they swap over to the other group, and the data is not usable as a randomized controlled trial. So the only data that we have so far looks promising, and that's why in the new guideline we wrote, HIFU can be used in patients if they are in a registry or in a study. So I really am looking forward to the data of your study. I like that a lot. You should not perform HIFU just because you have a machine. We still need the data.
And I think it's important not, I think it's important not to oversell HIFU either.
Yes.
I think it's very important that HIFU is not for everyone. When I started this study, I thought it was actually unpleasant to offer experimental treatment. So it's always easier to just offer patients standard treatment, surgery. The guideline says you have to go to surgery. So I think it's unpleasant. So I have tried to keep a distance, an academic distance to the technology. But what I see, even if I really sort of put it thickly on, there's risk involved. You may actually we end up having more metastasis in this group in the long run. After 10 and 50 years, patients still choose that treatment. I would have expected that a lot of patients say, okay, after I've heard you, I'm going for surgery. Maybe I'm still overselling it, but I'm actually quite conscious that I don't want to oversell it. But there's clear tendency, I think some studies show that too, that men are willing to risk an increased risk to have lesser side effects. And I recognize myself in that setting too. So.
Carlo?
When do you both think that it's prime time? I mean, how many years in the future before we will know that this is a good treatment for...
I love the question, but it's so difficult to answer. I personally believe that we are in a moment of change right now. We will get so more genomic data, other markers that are more important at the end. It might well be that half of the population I treat and I call significant cancer can actually be watched in active surveillance. But we just don't know yet. So the right thing to do is to offer those patients the mildest treatment possible, and that's HIFU at the moment. But maybe half of them at the end will need no treatment, but we don't know yet. So if you ask me in 10 years, will we have the data to show that HIFU is good or whatever? I think we will have more data on the genomic side, and then we can tell you, wait a minute, it's dangerous. In 5 years, this cancer can grow to be very aggressive, and then you'll get a radical maybe.
Another question from the audience. Microphone. Yeah.
Thank you. I like to present like the study that came out from the UK in New England Journal of Medicine in March, Hamdi and company.
That's the PROTECT trial, 15 years data.
The 15-year-old data.
PROTECT,
exactly.
yes.
Where they see no difference between radiation therapy, prostatectomy, or active surveillance in survival and death. And interestingly, they also see no use of Gleason score or the Amico score. And I wonder, where would you see HIFU fit in here?
So you are pinpointing the one most critical study at the moment, and all the experts in the world are debating this study. We don't know how to really focus on it. But I would say if we learn that most of the prostate cancers are not killing the patient, and I have a way to offer less to a patient, then I probably can offer less if I think it's the right thing to do. But we don't have the answers to the questions why it's all the same. It's very challenging, especially because the biopsies were done in a very old-fashioned way, only sextant biopsies. We don't know about mapping. There was no MRI. It's a completely different era. So it's difficult to compare to today.
I think it's important to remember too in the PROTECT trial, it was just first of all, the patients under active surveillance, 60% of those patients ended up with surgery and radiotherapy.
It's very high. It's double
very high,
the average.
So I think if you could just reduce that number, and that's sort of the thing I'm more. I don't think you gain necessarily a lifetime by choosing surgery or radiotherapy, but if you choose HIFU, you actually have the chance to achieve the same length of life, but you may not need radiotherapy or surgery.
The way I read it is that probably HIFU could replace a lot of the active surveillance, that you could reduce tumor mass at the early stage without having all the complications, instead of going directly to major surgery.
You have to rephrase again. So you're saying HIFU could replace active surveillance?
I say could not HIFU replace a lot of those patients that are in active surveillance? That you actually do something at an early stage instead of you having 60% going to radical therapy.
I think active surveillance is brilliant for patients with low-risk cancer. But my theme is, in a way, maybe we can extend active surveillance to patients with intermediate risk by using HIFU. I don't know if that works, but that's what we are looking at.
So any prophylactic treatment, you have to be really well defined and you have to know what you're doing. So removing breasts from females who have a high risk of breast cancer is already a big debate. And I think in BRCA, you can discuss it. In prostate cancer, we're far away from knowing that. Therefore, as good doctors, we should only treat the patient when we believe he has a profit from it. And I'm talking about this individual patient and not the whole group. Otherwise, no treatment.
I think we will close it there because we need a little break, actually. And then is there anything more to be said? We are on time now. No. Thank you very much.
Thank you so much.